Thank you for joining us for Diagnosis, Treatment Initiation, and Rationale for Treatment Change, Case Study Presentations. This activity is supported by independent educational grants from EMD Serono, TG Therapeutics, and the Catherine C. Moore Foundation. Before we begin, I would like to bring to your attention the target audience, as well as the accreditation information. I would also like to bring to your attention the credit designation and let you know that you will receive an email from education@mscare.org with instructions on how to claim credit for this activity. The faculty has reported the following financial relationships. It is my pleasure to introduce our moderator, Dr. Leora Freeman. Dr. Freeman is the medical director of the MS and Neuroimmunology Center at the Dell Medical School at the University of Texas at Austin. Now, I would like to turn the meeting over to Dr. Freeman.
Thank you so much, Laura. It is such a pleasure to be with you all today. And for those of you who have been a part of our webinar series, thank you for showing up every time. And this is our third and last webinar of this three-part series around MS diagnosis and treatment. For this one webinar, I am delighted to be joined by two of my close colleagues, Dr. Ethan Melter, who is a neurologist at our MS and Neuroimmunology Center at Dell Medical School at the University of Texas at Austin, and Alexandra Rossi, who is a nurse practitioner extraordinaire at the same MS Center here in Austin. Thank you both for being with me today. It is a delight to be able to speak with you. We'll move on to our learning objectives for today that are centered around recognizing situations in which we can apply the diagnosis criteria and the clinical scenarios where these criteria are not applicable. We're going to discuss some current recommendations for advanced testing using the approach to diagnosis and management of suspected MS in order to implement a diagnostic approach that is best for a given patient. And then finally, we will apply current knowledge and recommendations regarding evidence-based treatment and learn about shared decision-making approaches to make informed decisions regarding MS disease-modifying therapies. And with that, I will pass it to Dr. Meltzer.
Thank you, Dr. Freeman, for the introduction. So what I'm going to start with is a case really focusing on a diagnostic dilemma, which is actually quite a common occurrence here in our clinic, and I imagine clinics really across the state and the country. And one of the challenges, just before I even talk about the case, is many times patients are coming, they've had a longstanding given diagnosis, they've seen multiple neurologists, and how do we navigate this, wanting to go through the history, try and access these records that maybe are pieced together over the years, and then make sure that that we agree with the diagnosis, and how to do this really through the lens of hindsight, because it's hard if we weren't there 5 or 10 years ago or 20 years ago when the symptoms first started. A lot of it may not be totally clear. So let's just introduce the topic. This was a patient who initially developed symptoms at the age of 53, and really the dominant features initially were related to visuospatial disorientation. And I won't read all the text here, but this was someone who was very active. He was a runner, but started to feel quite imbalanced. When he would look around, he would become disoriented, really had to stop the things that he was doing in his daily life. This was relatively slow moving, and then over time, as things progressed, a year later, he began having some other difficulties. So, for example, when he was driving, he had a hard time staying in his lane. And this is pretty atypical for this gentleman. He was actually a retired pilot. So navigating a car, that was a pretty big change for him. He described it as feeling intoxicated, and even those around him, including his wife, started to note that he was starting to walk a little bit odd. And I didn't put it in the text here, but I think it's worth mentioning, none of these were these very distinct episodes, right? When we think about what is a clinically isolated syndrome, or what are these core clinical features that are typical of MS, Obviously, there's relapsing or remitting MS and there's progressive MS. These were all these much more subtle, gradual changes that he and others were noticing over time. So if we continue, now we're about 3 years into when his symptoms first started, and he's just continues to develop new problems. There's now some difficulty with cognition. His work performance is starting to suffer a little bit. He's seen physicians now, and they've referred him for neuropsychological testing that shows some deficits, as you can see here on the slides. And otherwise, a fairly broad review of systems doesn't reveal anything else at the moment. Although the symptoms that he started with, none of them have gotten better and they all continue to worsen. So at that time, he has then seen several different neurologists, and this was still a few years before I was seeing him in our clinic. And he had been diagnosed actually by an MS specialist with primary progressive MS and put on a MS disease modifying therapy. And we'll go into a little bit some of the data that they had available at that time and that I was able to review. And I'm now seeing him 8 years later. And so again, a little bit of hindsight here, but over essentially the 8 years, he's just had this relentless progression of his symptoms, cognitive, balance. He's falling now, and now he's developed some bladder dysfunction as well that's actually fairly limited, kind of limiting what he can do in his activities. Just a little brief note, in terms of just other history that we had picked up, he had 2 sons that were healthy. There wasn't really any strong family history of neurologic disease. He did have a sister with lupus, so there was some autoimmune conditions in the family. So at the time that I was examining him in the clinic, again, many years into when this started, the most notable things were really related to cerebellar dysfunction. And we didn't necessarily have the time to do in-depth cognitive testing. He was able to participate in the encounter fully. The things that really stood out is he had this bilateral direction changing nystagmus, clearly indicating some sort of cerebellar problem. He had lots of impairment using his hands for rapid movement, as well as his legs, and a very wide-based gait. Couldn't do heel to toe, couldn't tandem. And so the most dominant physical manifestations that came out were all related to this cerebellar dysfunction. So next, what I have is just a series of images, and it's always a challenge, especially when someone has had a diagnosis for many years. They've had lots of MRIs, and so I've tried to get some representative ones over time. They didn't actually change too much over time. Trying to point to features that, okay, if I were an MS specialist or a neurologist, what were the things that would build that argument for MS? And so this is a MRI sagittal flare sequence, and I have little arrows pointing to some of these hyperintensities, and we'll talk a little bit more about this. But for example, we can see coming off the ventricles, there are some of these periventricular lesions, maybe pointed to one or two that seem a little bit more kind of perpendicularly oriented, radiating outwards. And then there also were some hyperintensities actually in the cerebellum, and those are the lesions that likely explain his symptoms. The next perspective I'll show you is just an axial view where we can essentially see some of the same findings again. So on the left here, we again see these periventricular lesions, and there's some features that stand out both in the sagittal and the axial cuts, which we'll talk about if we're trying to make this judgment of, do these seem to be more consistent with demyelinating disease or not? And there's some features here where they're very linear, they're somewhat capping the ventricles, that are, I wouldn't say maybe not necessarily red flags, but are things to consider. Are these the classic demyelinating lesions? We'll go through some papers that look at that. He also had some changes in the brainstem that I point to here that, again, don't necessarily fit with this classic MS pattern. I don't have pictured here is there was actually a complete absence of spinal cord lesions, which I think is really critical, which we're going to talk about when we think about how to or can we apply McDonald criteria in this case. So the spinal cord had been imaged several times over the years, and even if I'm seeing him 8 years later, there were still no findings in it. And then lastly, I just wanted to show you a little bit of a better view of these lesions in the cerebellum. And so when we think about the kind of what we're looking for on the MRI, one of the key locations is going to be infratentorial lesions. And so in his case, if you go to the next slide, what we'll see is we see these lesions in the middle cerebellar peduncles. And just have arrows pointing to both of them. And the one thing I would call out here, not that it necessarily rules out MS, is that these are very symmetric. And we'll come back to this. Lesions in MS, yes, they're hot spots, but they tend to be fairly random. And of course, someone could have symmetry, but often we really don't see a lot of symmetry with these lesions, just given the randomness of it. And so this was something that kind of when I first looked at it made me a little bit puzzled of just saying, okay, there aren't that many times often I do see lesions in the cerebellum or the peduncles or the brainstem, but usually it's not these two very distinct spots that look very similar. The other data that was available is he had a lumbar puncture done by a prior neurologist. And if you show the next slide, critically, what it showed is that there was no inflammation in the spinal fluid and no unique oligoclonal bands. Those were absent. And then people had also looked for various serum markers for other diseases. These have been checked multiple times over the years, and those were also negative. So this is the dilemma that we're often faced with is we're trying to do, we have kind of the benefit and also the hindrance of hindsight in that we're getting this history years later. We can see how the story has unfolded in front of us. We can see the data, but it is a very tricky conversation to sit there with someone who you've never met before and say, hey, I want to make sure that the diagnosis you've been given and you've been living with the past 5 or 10 years or however long it's been, if I agree with it or not. And so often this is not something that I tackle just in one visit. This is not something that unfolds just in a 45-minute first encounter. It's something that I tend to want to take my time on. And so can we apply the McDonald criteria to this situation? Is this something that we should be doing? And I think there's some pitfalls here, and I include a quote because this is from Lancet Neurology. This was the last time that this was a 2017 criteria, though now there will be the 2024 criteria. And I think the key here is that this was not necessarily developed as a tool to distinguish MS from other conditions. This was really used as a tool when there was already a very high, what I would say, pretest probability of MS and a very low pretest probability of other conditions. So we really shouldn't be using this to try and narrow down the differential. We should be thinking about the differential first, and then if MS is most likely, does it fit with this? And so really, I think about the emphasis that it needs to be a very typical presentation, and other things need to be unlikely. And yes, MS can be atypical, but I'm not going to use the criteria to shoehorn a patient into that diagnosis. So in this case, especially since he had never had something that seemed like a typical clinical relapse, we're really operating in the realm of progressive MS, and that's always a little bit tricky. And so in the 2017 criteria, the way that it's laid out is that individuals need to have progressive disability, independent of clinical relapse, and that makes sense, plus 2 out of 3 of the following criteria. So maybe starting with the easy ones would be the bottom 2. So they need to have lesions within the spinal cord, and those are very highly specific for demyelinating disease, or can be, or the presence of CSF-specific oligoclonal bands. The top one is having characteristic lesions in multiple brain regions. And, this is maybe a little bit trickier, which we'll talk about in the next few slides. And so even if we just pause here and we think about the case, and we'll kind of come back to this, there's already a little bit of a problem because our individual doesn't have lesions in his spinal cord, and there are no oligoclonal bands. Now, again, that doesn't necessarily rule out MS, but you can see how this is already a little bit of a challenge. So when we think about the use of MRI, because this has become such an important diagnostic modality when we think about MS, we want to think about where the lesions are, what we might want to call green flags, what are red flags, and then what are characteristics that might suggest alternative diagnoses. And so there's a very helpful paper that was published in Brain in 2019, and we have a table here that kind of goes through this, and there's a lot of writing on it. So it's intentionally a little bit small. It's a good thing to reference, probably not a good thing to memorize. But it goes through what are some of these typical features we might be looking at. And I think it might even just be helpful to focus in a little bit on some of these supratentorial lesions. So things that are periventricular, subcortical, what are things that point us towards demyelinating disease or away from it? So if we go to the next slide, there's this paper includes just some really helpful pictures that I think demonstrate this really beautifully. And so we can see on the far left column, these are green flags. So these are patients with a confirmed MS diagnosis, and you can see they abut the ventricle. You can see they're this nice ovoid shape. Whereas red flags, you can see many of these are disconnected from the ventricles. These are, or the cortex, they're much more subcortical. We can see this capping. We can see this more kind of linear appearance to some of them. And then in kind of E and F, some of these just have patterns that are very distinct where they're only found in very specific regions. And then kind of the last column is just highlighting that there's a lot of things that may at first look like they're periventricular, but in reality, they're actually a little bit disconnected and they're really just found in the deep white matter. And so, I always find that this is one of the harder parts is if I'm looking at an MRI, trying to make some of these judgment calls. And we might talk about it a little bit later, but one of the things the 2024 criteria does is try and give us a little bit more specific markers that help us to guide, should we count that white spot or not? Which I find is always tricky. And Dr. Freeman, I'm sure you can attest to this, but sometimes this looks different over time. So I've had patients where I saw them in clinic and said, I'm not sure about the MS diagnosis, and I'm looking at their MRI. And then I had one very notable one where we talked about this several times, and then finally she was able to get an MRI from something 10 or 15 years ago, and sure enough, it looked classic for MS. And I thought, okay, so it is always a little bit tricky looking at this later on.
Yeah, and it's important to, with what you just mentioned, it's like sometimes, we have the MS process and then we have the superimposed aging and things that
Yep.
happen in the white matter, and
Yep.
that can confuse the picture. So as much as we can, I love your advice of like going back and, really
Yeah.
tracking down those MRIs and how it started is often very helpful. So thank you for this, Pearl.
Yeah. And then I think it's also helpful just to think about, especially as an MS specialist or working in an MS center, there's always this challenge of this really hard bias, right? Because we are referred a biased population. So if someone's being sent to me, there probably is a high likelihood they have MS. But at the same time, if I have a hammer, I don't want everything to be a nail. And so I'm always trying to walk this line of, okay, I know that my patients are likely to have MS or some other demyelinating disease, but not everybody. And so some studies have looked at this. So there was a really cool real world study that looked at this across 22 MS centers, close to 700 patients, where they look through, and these were all individuals referred to an MS center for possible MS. And so these are likely patients that have already gone through a fair amount of screening. They've seen good physicians, neurologists, maybe even other MS specialists. And if you look at it, it's pretty striking. So of those patients, even just right off the bat, I think, what is it? It's 94 patients. So about 14% had an alternative diagnosis. So right off the bat, there's already a pretty large subset of these patients who were given a not MS diagnosis. I think even scarier, honestly, as a physician, is that there are a large part where they said, okay, yeah, you did have MS, but the other really big number, about a third of them, it was inconclusive. And I think what this points to is that kind of something I said before is we can't rush into this. Often you have to see this over time and you have to follow these patients up. And of that cohort where there wasn't an answer initially, they followed these patients up, and a large number of those patients ended up having an alternative diagnosis, but many of them it still wasn't clear. And so I think this is just one of these examples that neurology is just so humbling, that these patients can be seen for years and years, And I think the number ends up being about 15% of them still don't have a confirmed diagnosis of MS or something else. And so I'm always very cautious about giving this diagnosis or taking it away because the data really shows that there's a lot of folks who are being referred to an MS center for possible MS that actually have something else. And if we aren't really being cognizant and at least being aware of it, it's not that I have to question it every time, then we might be missing some of these other conditions. And there are certain features that came out. I don't want to spend too much time on this that seem to predict an alternative diagnosis. And that one of the strongest ones was actually absence of oligoclonal bands. And I want to highlight that one just because it is a test that is often obtained. It's one that's relevant to this case, and it's something that that I think does come up pretty frequently. And honestly, some of my most challenging patients are the ones where that is negative, and I just like, ooh, I always think of this paper, and I'm just, it makes me nervous. So, going back to our case, just putting this together, what we have here is we have a 53-year-old man has this slowly progressive syndrome that I would define as cognitive cerebellar with this leukoencephalopathy, right? And within the MRI, the notable feature that stood out to me was, there's nothing that's very specific in terms of, spinal cord lesions, but he has this kind of odd symmetric middle cerebellar peduncle lesions. And then he has this absence of oligoclonal bands. And so red flags here would be, somewhat atypical clinical course, although maybe you could argue that, progressive MS, it's not that common anyway. He has no oligoclonal bands. These periventricular lesions, and I'll show them again just very briefly, didn't really have those classic features and, the capping, these linear characteristics. And then he didn't have spinal lesions and he didn't have typical infratentorial lesions. And so thinking about that criteria, even if we wanted to apply it, he doesn't necessarily meet it. And so just showing you real quick the MRIs again, just now that we've kind of talked a little bit about it, you can see it's not this slam dunk, findings that we might really otherwise be expecting. And then I'll just show you the cerebellar regions again. And so when I saw him, it took me, this was not all in one visit. It took me a few visits. And at some point I just kind of looked at the MRI for maybe the third time I'd seen him in clinic and I just thought, that's kind of odd. And, I'm not that far out of my training, but I'd obviously forgotten this or never learned it from studying for the boards. But I thought, is there something that causes just middle cerebellar peduncle lesions? And I think that this is one of the beautiful things about neurology is, if you kind of step back, you don't have to know everything, but if you can kind of find the salient features, hey, this is this progressive cognitive and cerebellar syndrome with these odd middle cerebellar peduncle lesions. I just sat down and I Googled it actually, one day in clinic with him. And on the next slide, I took a screenshot. And, maybe my Google search history knows me pretty well and takes me to what I want to see. But if you look at my top results screenshot, not from the day of, but the first and second results would take you to papers. And if you just do a control F for the paper, it takes you to, oh, well, there's this syndrome, Fragile X tremor ataxia syndrome, that is commonly associated with the middle cerebellar peduncle sign. And so ultimately, that is the answer to this case, and I'll wrap it up. But this is actually a condition that is, it's not common. It's a neurodegenerative disorder. It's the same expansion repeat mutation that is seen in Fragile X syndrome, except it's a pre-mutation range. And so individuals who have Fragile X syndrome, which is this childhood onset developmental delay, they have many repeat expansions. And then in this range, it's more than what it should be, but not enough. And this actually causes this adult onset syndrome that actually fits quite well with our patient. They can get this leukoencephalopathy, or probably better to say leukodystrophy, that has some of these key features. So what I'll do is maybe I'll stop there, but hopefully this is a helpful case, not in that I'm seeing this type of thing and diagnosing it all the time, although since that time I've actually had a second patient where we've made that diagnosis. But it's just something where I think it's always critical just to trust but verify, I guess. Is to review the data, look through it, and don't rush into either giving the MS diagnosis or taking it away.
No, it's an exceptional case. I really love how you walked us through it and your thought process and how it happened, and the time that it takes. And I think that's really important. I mean, we want to have timely diagnosis of MS, but we don't want to have timely misdiagnosis of MS. So that's really important to really take the time when time needs to be taken to really have diagnostic certainty. Before we go on to Alexandra's presentation, I wanted to kind of ask you your thoughts about, now we're moving to the 2024 diagnostic criteria, and we talked about this in one of our previous webinar, and those new diagnostic criteria are actually trying to take the emphasis off the clinical presentation and onto the imaging biomarkers, trying to even diagnose MS before it even manifests clinically. So now we're like, we have to really put the emphasis on those red flags, green flags of, MRI markers, and we're used to looking at those kind of T2 flare imaging. What do you think the new biomarkers, the central vein sign or the paramagnetic rim lesions is this going to be helpful to us in cases like this one?
Yeah, that's a great question. And yeah, it's absolutely wild that we can now diagnose MS in individuals who never had a symptom, right? That's a complete paradigm shift in the way we think. But I find it helpful. It doesn't solve diagnostic problems, but I think what it provides is it provides an additional MRI site that, at least to me, that can provide that high specificity. And I think that that's one of these challenges, is that when we see some of these individuals where it's an edge case, okay, if they have a nice, small, eccentrically placed lesion in the spinal cord, or two or three of them, that to me, and not just to me, right? Those are highly specific for MS. Whereas if you showed these periventricular lesions of different patterns to radiologists or MS specialists or neurologists, there probably is a lot more play in terms of how people would label it, and the specificity goes down. It's not ruling in MS as well. And so I think part of the beauty of things like the central vein sign, the paramagnetic rim lesions is, I mean, even for the paramagnetic rim lesion, I think it's having at least one was exceptionally specific. The central vein sign, I think it's 45% or so. But this is just providing to me another site on the MRI where we can obtain this high diagnostic specificity in the right clinical context. And so I do think it's very helpful for these patients, and I'm sure you see them as well. Yeah, I mean, maybe MS just isn't involving the spinal cord. And when that, and that happens, right? And when that's the case, um, I feel much more comfortable if I say, okay, yeah, I have data that, okay, that spot is not a UBO, an unidentified bright object. That is something related to demyelinating disease.
Yeah. No, I think it's going to be really interesting to see the proper implementation of those new biomarkers, and particularly in patients like this that are over 50 years old. There's all kind of things that, even in the context of aging, as we mentioned earlier, can contribute to white spots, and it becomes a little tougher, and we need that specificity. So thank you for this, phenomenal case, Dr. Meltzer. And now I'd like to introduce Alexandra Rossi, who is going to talk to us about treatment changes and difficult conversations around treatment changes. And I want to remind all of you that you can open the Q&A box and place your questions in this Q&A box so that we can get to them at the end of this webinar. And with that, Alexandra, the floor is yours.
Thank you, Dr. Freeman, for the introduction. So as Dr. Freeman mentioned, I will be discussing treatment changes in a patient with MS. Very eloquent talk, Dr. Meltzer, about these atypical cases. I will tell you, my case is not as mysterious, but I think it yields a kind of what to do in these pickles that we inherently get into in practicing neurology and MS patients that might not be obvious. And really, we don't have clinical practice guidelines when it comes to what to do in some of these pickles. So hopefully this case is helpful to you in practice. Okay, so we have a 75-year-old African-American man with secondary progressive MS. He is on siponimod, also known as Mayzent. So his history of present illness, his medical history is pretty simple. He has anxiety, he has Hep B, he has a chronic lumbar spondylosis, some other chronic illnesses. His social history, he's married, he has a son and a daughter. Interestingly, he worked EMS. He's retired now. He's a former smoker. He has no allergies. One thing I do want to mention, I want you to kind of save this in the back of your mind for further discussion down the road in our conversation, is that his grandfather lived to be 110, and then his mother lived to be 98. They had no known illnesses. Okay. So again, this patient has MS, but we'll talk about kind of how he presented. So July of 2009, again, thinking of age, he presents at the age of 60. He has an initial visit with a general neurologist. His first symptoms were that he started to experience left leg giving out with walking, which progressed over 5 months without resolving. So very characteristic of these focal neurologic deficits that start, either acutely or subacutely and get worse over time. He also reported an episode of right vision change about 2 years ago. So perhaps, maybe this started where he was, 58. It resolved within about 10 days. Again, getting worse over time and then resolving. So he had an MRI, his initial MRI at this time, and it showed some white matter signal abnormalities consistent with MS. Again, Dr. Meltzer kind of went through what looks like MS, what doesn't. We'll go through that in the imaging here. He also had a lumbar puncture. His CSF showed the classic 7 unique illegal clonal bands, so very confirmatory for an MS diagnosis. And like some patients, in the 2009 era, he was started on an interferon beta, also known as Avonex, very commonly used medications at this time. And you can see here on the right, just kind of this, basic illustration of what you should expect when your patient presents. So acute changes to vision, stiffness and spasms, numbness or pain, loss of balance or ataxia. And sometimes you can see these cognitive and mood changes, but less likely with your presenting symptoms. Next slide. Okay, so his initial MRI. So here you see, especially in the axial view, you see these ovoid shape lesions, and they're T2 hyperintense. They, again, abut the ventricles. So you see these kind of little circular-like things that really abut right up next to the ventricles, very classic for MS. Again, noted are some juxtacortical lesions and subcortical lesions on both sides, as well as correspondent with this right visual loss symptom that he explained earlier. We see on MRI a right optic nerve neuropathy. And again, on his initial MRI spine, here you see these vertically oriented focus of abnormal signal and these faint enhancing lesions, so some active lesions at the time at C5, T3, and T4. These are very short segment lesions, which are classic with an MS diagnosis. So fast forward a couple of years, he finally gets in to see a neuroimmunologist. He's now 67. He remains on Avonex, again, not uncommon at that time. Although he reports some worsening weakness of his left leg, his presenting leg, and he continues to report worsening balance. He now requires a cane to ambulate, which is a pretty significant change in that amount of time. And the physical examination by the neuroimmunologist shows an objective worsening of left lower extremity weakness, spasticity, and sensory changes of the lower extremities, all very classic MS findings. So here we have kind of an interesting progression over time. So I want to note that the 2 MRIs that you see on the left-hand side are the 2008 MRIs. So the older MRIs that you see, kind of a mild, moderate burden of disease. Again, classic what we see in MS, kind of these finger-like projections that come up above the ventricle, also known as Dawson fingers. And then we have the MRI on the right. So you see this notable increase of disease burden over here on the right in 2016. So very correspondent with this lesion progression. And what we're seeing clinically is that the patient's just continuing to worsen. So what did the neuroimmunologist do? So in 2016, the patient was switched over from the Avonex with interferon beta because of this progression to a higher efficacy drug, right? And at that time, fingolimod was a higher efficacy drug, and this was due to breakthrough disease, new lesions on MRI. Fast forward to 2019, a couple years later, he continues to progress. So patient continues to worsen. At this time, he's diagnosed with secondary progressive MS, so more of a progressive phenomenon rather than seeing new disease activity bubble up in these relapsing remitting forms. And he switched over to siponimod or Mayzent that does have an indication over fingolimod for secondary progression. So keeping with our MS history, in 2023, the patient is now 75 years old, okay? Again, kind of this point of discussion of age and being on disease-modifying therapy. He's been radiologically stable for years, so his MRIs haven't changed. We haven't seen any new lesions. Yes, he's progressing in terms of symptoms, but his MRIs aren't changing. He's progressing in gait, his balance is off. He's now in a wheelchair. Of note, and of course, you know, the thing that we worry about is that he's having these recurrent UTIs. His ALC, which we monitor in fingolimod and Mayzent, of course, is appropriate. It's not too low. We're not putting him at too much risk for, you know, a disproportionate risk for recurrent infection. So the decision by the neuroimmunologist was made to transition him off of siponimod. And the way that they did that is they had the patient take siponimod every other day for a month and then stop. So I've already kind of alluded to it. Again, my case is not mysterious. If this was a murder mystery, you'd be kind of like screaming the answers at me. But there's a couple takeaway things here. So what's the rationale for discontinuing treatment as patients age? And we'll just talk about kind of some key theories that we see. Kind of plain and simple, we see lower relapse rates observed with older people with MS. There's a very linear graph here on the left-hand side, which is nice and neat, that we see the annualized relapse rate really decrease from the years of onset, right? So you're diagnosed and your rate of relapse has this nice downward trajectory when you get further away from the years of onset. Again, remembering this patient's age. And then over here on the right, you see the annualized relapse rate correspondent with the patient's age range. You see, you know, kind of higher rates, of course, in the 20s and 30s, really peaking in the 30s, but really starting to decline at this, you know, 40 to 60 age range. Okay. And in keeping with this patient, the burden of infection increases with older persons with MS. There's a couple of reasons for this. So there was a Canadian cohort study that looked at infection-related hospitalizations of persons with MS with matched controls. And what you see here, of course, is persons with MS in all of the age ranges, but specifically in those older than 50 years old, had a higher incidence of risk of infection and related hospitalizations. Most common urinary tract infections, infections of pneumonia, intestinal infections, skin and subcutaneous tissue, and of course the one that we worry about the most, sepsis of any of these systems. And why is this? This happens because of this very fancy word that you can now use to impress your colleagues called immunosenescence. So this is an age-related decline, very simply put. This is an age-related decline in the function of the immune system. This happens to patients both with MS and patients without. This happens to the general population. I will note that there's a range of age. This doesn't, you know, exist in a vacuum, and it's different for every person. And so there needs to be a consideration there as well of when does this start to happen? Does it happen differently in males versus females? And of course, this can lead to increased risk of infection and weaker response to vaccines. This is especially important that we think about those that are still on disease-modifying therapy. So really a risk-benefit conversation of those that are on disease-modifying therapy in keeping with the phenomenon of immunosenescence. So, so this is actually where I had met this gentleman a couple times before in 2013, and this is where I meet this gentleman. So this is approximately 6 weeks after stopping the siponimod. This patient comes to me and he actually presents to clinic. He shows up into clinic and he shows up before hours. I get a call from my staff, and he's asking where he gets his MRI. And we're a clinic, we don't have MRI access here. He's been a patient of our clinic for years, and so he seems, kind of impaired, not, acutely impaired or altered level of consciousness, but his thought process just seems a little bit off. He doesn't seem oriented to where he is. I kind of ask him, how are you doing? I get him in for a work-in visit, direct him towards his MRI, and he says, when he gets his MRI and he comes to the visit, he says, I kind of feel the same. It's been this, ongoing continuous decline in my lower extremity weakness, specifically on my left, kind of the same old thing, but just really getting worse. He didn't say anything changed, acutely, but just says, I'm just overall not feeling as sharp, not feeling as well. Okay, so here we have the MRI that he got right before he saw me. And unfortunately, what this shows, and you can see when you think back about that 2016 MRI, is a notable increase of subcortical deep white matter lesions. He has new periventricular and deep white matter lesions, and new lesions in the left anterolateral medulla. So really supratentorial, infratentorial, just, lesions kind of just spread across everywhere. Next slide. And this is a post-contrast study. So he has multiple areas of enhancement, and you can't entirely see on these images, but he had over 5 gadolinium enhancing lesions. So new lesions that were actively lighting up right then. I want to draw attention to kind of the nature of these lesions here on the axial cut on the left. Again, these ovoid kind of ring-like lesions that abut the ventricle up in the top. And these subcortical lesions, the one on the right here being the medullary lesion. So again, not very mysterious, but some easy things to think about. What would be your differential diagnoses in this case, right? There's a lot of things that can cause new MRI findings, new enhancement on MRI. Is it malignancy, infection, PML, right? PML is something that we always worry about in patients that are on disease-modifying therapy, specifically those on natalizumab or Tysabri, and your S1Ps. Or is this rebound disease activity associated with siponimod or MASENT discontinuation? So you can kind of think about your answer, and we'll come back to why and what to do. So, so with these findings, we say, well, this isn't good. We need to work up, of course, rule out some differential diagnoses, determine if this is in fact rebound disease. So we admit him to the hospital next door, and he has a pretty benign workup. Everything comes back for the most part negative. His ALC is actually is back to normal. His CBC is normal, his CMP is normal, all of his organs are working correctly. His CSF findings are bland. He is diagnosed with a UTI, which doesn't really explain much. This has historically been his case. He's had these UTIs. And in terms of malignancy, looking for systemic malignancy, his CT chest abdo-pelvis was negative. So very reassuring there for us. And so we with this information kind of went back to our MRI findings and looked at his most recent clinical trajectory and said, yes, this is in fact, we have 5 GAD enhancing lesions on MRI. They look very much like an MS pathology, and it is in fact rebound association with siponimod discontinuation. Again, looking at the timeline, 6 weeks after we stopped siponimod. So what is rebound disease with S1P? Again, this class of medications that both Gilenya or fingolimod and siponimod or MASENT fall into. So reactivation is defined as post-discontinuation neurologic disease activity that does not exceed the highest level of disease activity recorded before treatment. So reactivation is this phenomenon where you can have these new disease activity, whether it's, T2 lesions or GAD-enhancing lesions, but it doesn't exceed what they started with. Rebound is considered severe disease reactivation after discontinuation, specifically to include 3 or 5 GAD-enhancing lesions and or tumefactive demyelinating lesions on MRI that must be coupled with worsening clinical function. An activity that exceeds the pre-treatment baseline inflammatory activity. Again, looking for kind of this like profound recurrence of disease. Next slide. Okay, so this was a study actually looking at exactly that. So prevalence of disease activity after we stopped S1P modulators. This is a multi-center retrospective study, specifically on patients with fingolimod, so the same class. And I want to draw attention to the numbers here. To me, this is quite profound when we look at percentages. So 20% of patients experience rebound disease when coming off of fingolimod. Another 11% of patients experience disease reactivation. So when those are taken together, you have a pretty high percentage of patients that are coming off of an S1P that are experiencing new MRI activity. And the median treatment-free interval after cessation was about 1.5 months. So again, things we need to be thinking about, percentages of patients that are having new disease activity when you stop fingolimod or any S1P. Next slide. So what's the prevalence of disease reactivation after S1P modulator discontinuation? This is, a lot of the same conversation, but a little bit of different numbers. So this is a Finnish MS register study, so about 144 discontinuations. Again, what we find was about 28% were followed by a relapse. Of those, the N of 20, 17% were just an ordinary relapse, and then a 10% were rebound relapse. Interestingly here, the time to relapse was about 8.5 weeks for ordinary relapse and 9.9 for rebound. And again, the rebound group was younger and had used fingolimod for longer. When we think about how this affects us in real-time practice and what we need to be considerate of when transitioning off of these medications or perhaps switching over to a different medication, is their half-life, right? So half-life of medication impacts time to disease reactivation. So some key things here in the classes of medications that we worry about rebound disease. So natalizumab or Tysabri, 11 days, right? You have a little bit longer here. Fingolimod, as we were talking about earlier in these studies, were 6 to 9 days. Siponimod with 30 hours that we saw in our patient, and ozanimod is quite a bit shorter. So what do we do with these patients? In these patients, we look at studies where patients have been transitioned off of these therapies onto other therapies. So this is an interesting cohort study where patients were switched from fingolimod to rituximab. And in that study, they found no case of rebound in the patients that were switched to rituximab, while those who were switched to cladribine, which is a different disease-modifying therapy that's a reconstitution therapy, rituximab being a B-cell therapy, they found about 21% of patients experienced rebound. And again, on the bottom here, we talk about new MRI activity not considered rebound, happened in about 54% of patients who switched to cladribine, and those who switched to the B-cell therapy was about 30% lower, so 20%. This is another cohort study, and it just really emphasizes, kind of the what to do when we talk about transitioning patients safely off of S1Ps. And I think the data really proves it here. So we saw a higher incidence of rebound in patients that were transitioned to cladribine and a much lesser number in the patients that were switched to B-cell therapy. And this data kind of proves it. So this was a cohort study of patients that were switched from S1Ps to anti-CD20s or B-cell therapy. And we found that 4 of the 108 patients experienced relapse, and only about 7% of those had GAD-enhancing lesions. So a much lower number than those on cladribine, and certainly a much lower number than patients that just stop S1Ps abruptly. And so as we can kind of take this all together, my key takeaways for you in this case is before stopping an S1P or even natalizumab or Tysabri, please consider the risk of disease reactivation or rebound. There's a couple key factors that indicate higher chance of disease reactivation. So younger age, right? Oftentimes more aggressive disease with the younger age, as we saw in our charts. More relapses in the year prior, so you have a higher disease activity in the year prior or during fingolimod. Those with disease activity have a higher risk for rebound. More GAD-enhancing lesion, again, same idea. If you're having GAD-enhancing lesions and active disease activity and you stop fingolimod abruptly, of course your risk of rebound is going to be higher. And a lower lymphocyte count on fingolimod. There's some theories behind that. We can talk about that a little bit later. But the real key take-home message that I hope everyone here gets is to mitigate the risk of disease rebound or reactivation. We really should consider kind of gracefully switching these patients off of therapy by introducing an anti-CD20 and then kind of discussing how long we need to treat with an anti-CD20, which may only be 1 or 2 doses to prevent rebound disease.
Thank you so very much, both of you, for this presentation. Alex, so many interesting nuggets in this case. I think the first thing I want to kind of briefly talk about before asking you a question is what's really interesting is that this patient didn't have much complaints, but you perceived that there was some differences, and that really brings on the topic of cognitive relapses. This is something that has been described in the literature more recently, that sometimes patients may experience relapses without physical symptoms, but truly with clinical, only cognitive worsening. And that's really, that there's really just literature that has, been very interesting about this, how, we see cognitive changes during relapses in people with MS, but we can also see folks who present with no other symptoms and just cognitive worsening. So that's I think one really important nugget with this case. I wanted to ask you, you mentioned the longevity and the age of onset of this patient, and that's really brings me like very find it very interesting, because age is just a number, right? So age is just a number. I'm not, as old as, I would like to, I would like my passport to say a different number, but that's, that's a consideration here. But
Me too.
in the case of this patient, how do you think this family history of longevity, this age of onset have played a role in, this association with this, rebound of disease activity we're seeing here?
Yeah, it's an excellent question, and I think there's a lot more work to be done at looking at how inflammatory disease can be with late onset. So you think of this patient; he has an onset at age 50, and if you just take our basic studies that we looked at with age of onset, and you put that anywhere kind of in the range of ages, and you look at disease trajectory, it is more inflammatory when it presents, right? And so if we took that kind of in a vacuum and we said, yes, the patient isn't 30 years old like our general population, but perhaps he presents, 30 years later, and he still has this inflammatory propensity for much longer than we would consider, our normal patient population. I think it's important to kind of be nuanced about that. I think there's several theories floating around. Our colleague Jen Graves talks about, genetic predisposition and perhaps maybe phenotypes where patients just have, this longevity, and maybe MS looks a little bit different in the patients that present later, or they have, different genetic components where they have longevity. So certainly a lot of interesting theories, but in retrospect for this patient, I think we should have considered that perhaps his inflammatory period would last, far beyond what we usually see in immunosenescence.
Yeah, no, it's really interesting, just the concept of biological age and, that how that impacted this patient. I wanted to also ask maybe either of you, how do you approach in these aging patients? Sometimes it's hard to, I find that some of our patients absolutely do not want to get off treatment. That sometimes is a conversation that needs to be had. How do you approach that conversation? And how do you approach maybe the challenges of the infection risk? What else can we do besides discontinuing this disease modifying therapy? Maybe Ethan, you want to jump onto this one and kind of work us through your approach.
Tough question, and I would say, I imagine that you would probably agree with me. It's honestly the question I get asked the most now. And it's interesting, putting it into context, and maybe I'm somewhat avoiding your question because it's a hard one to answer, is often when I'm having a conversation with patients, it's to me, it's such a different way that we now view MS, which is we have this generation of folks who've been diagnosed with MS early in the course of the disease. Often, thankfully, they're very mildly affected, and and partly because of the early diagnosis and then starting highly effective treatments, that now there is this wave, right, of individuals who we are seeing in clinic, which is an amazing thing, where they're doing so well that the question isn't what can you get me on to keep me from worsening? The question is, all right, I've been on this treatment for 5, 10 years now. I've been completely clinically stable. My MRI is totally stable. Is it safe to come off ever? And then if so, when? And to me, it's just fascinating that, yeah, I agree with you on the age thing, although clearly I'm not old enough that, I was there back in the day in 1993 or 4, when these things are coming out. But like, just to imagine what this conversation is now and how it plays out now compared to even, even 10 years ago or 20 years ago for so many individuals where the entire narrative of MS is flipped. And I just find that so fascinating. I had that conversation, I don't know, 2 or 3 times today alone. And I always frame it in terms of risk and benefit. And and that to me plays so much of a role of what medicine they're on. So for example, I was seeing an individual, long-standing MS, thankfully has done very well on an interferon. And and I frame that conversation very differently because the risk of that compared to someone who maybe has been on long-term immunosuppressive therapy and they have hypogammaglobulinemia and they're having infections is totally different. And for this individual, maybe with this concept of immune senescence, maybe it's not as effective as it was when he was started on it. I can't remember what it was, 15, 20 years ago. At the same time, if the risk is really low, you know, am I pushing that person to come off treatment? Probably not that hard. I'm still open to that conversation and talking about it. But that's very different than an individual where there's potential clear risk for harm. And so often I frame it that way. I pull up the data. It's fairly limited, but kind of what we have to kind of try and put it into context. But it's really challenging. And one thing that I've started to try and do is incorporate some of these newer metrics, such as checking things like serum neurofilament light or some of these other panels that are commercially available. It's a little bit of a double-edged sword because we don't really quite know what to do with that data sometimes, but trying to look for other ways to have some objective ancillary marker of what is their current disease activity, which to me is trying to inform what is the benefit. Because the risk is often pretty obvious, and it's fixed. It's the benefit which is hard to define. I don't know. Did I sufficiently avoid
Yeah, no,
your
I
question?
agree with you. I think it's great to think about the novel biomarkers as like personalizing that conversation. I think it's also important to like maximize care for infection. I know we talked about before this recording about, like how can we really enhance preventive care for our aging patients, vaccinations. All of this is really important to really work hand in hand with primary care providers or even provide that insights for our patients. So yeah, I think you nailed it when you say, we can assess risk. It's really hard to assess personalized benefit to patients. And that's where I hope we get, research insights, into all of this. I know we're coming up on time, but I want to one last question because this has been just such a fascinating conversation. Alex, when we talk about treatment discontinuation, aging is not the only time across the lifespan. we're having these conversations also with, women of childbearing age who are on certain therapy that, may not be compatible with, conception and pregnancy. How do you approach kind of this period of the lifespan with these women, and planning for pregnancy? What are usually kind of some high level kind of takeaways that, we can bring to our audience today?
Yeah, that's a great question. And I have this conversation often with my patients. I think that there's still a large cohort of patients, that got diagnosed early and that are still on your S1Ps, and their disease may be well controlled, but certainly, not the best option, in my opinion, for planning a pregnancy. And so my instruction to them is always have a conversation early and often with your neurologist or your neurology specialist. About how to safely transition. And really the answer for me for patients that are on S1Ps is the same for those that we talked about today. Is the safest way, I think, for patients that are planning pregnancy is to transition to a B cell therapy. It's not everyone's choice, but certainly, kind of gives you the most bang for your buck in terms of maximization of coverage, and being most compatible. We have some data on, B cell therapies in patients getting pregnant, with some timing afterwards. So that's usually the conversation that I have with them. But also being very mindful, and this, applies to patients at any age, again, that are on an S1Ps. I think, as prescribers, we have an inherent responsibility, whether we're starting this medication, whether this patient comes to you and they've been on an S1P, to talk about the risk of rebound. And that happens at any stage. There's different variances to how severe it might be based on the data that we discussed, but certainly a conversation that you want to have.
Yeah, no, I think this is really important, not just for S1P, but also natalizumab that's associated with risk of rebound and disease reactivation. I think it is truly our responsibility because let's face it, most of the time patients discontinue medication, not because we've asked them to, but because, insurance, coverage disappears because they run out of their meds, because they have access issues to their medication. And this is really can have really just very dramatic and awful consequences for patients on some medication. So it's important to really inform folks up front about those risks that they know to contact you should they lose coverage, should they lose access, should they become pregnant. This is all extremely important to emphasize. So thank you for this. And, and the pregnancy conversation is one I hope we can have in the future. But, that I think really applies. All what we've learned today also really applies to this time in the lifespan. So thank you for educating us on this. And I see Laura come back. So I know it's time for us to close.
Thank you so much. It's so interesting to look at real life stories and really dig into the cases of patients. So thank you for sharing that information. You've left us with a lot to consider this evening. And as we conclude, I'm going to share my screen one more time. If you would like to stay connected with Can Do MS, you can follow us on social media. And again, I would like to thank our panel for joining us this evening, and wish you all a great evening. And thank you all for joining us tonight. It's been a really wonderful series that we have provided. All of these webinars are archived on the Can Do MS website, and we hope that you enjoyed this webinar series. So thank you and have a great evening.
Thank you all so much.